A very good morning to everyone. I will be talking about a specific type of randomized controlled trials called the non-inferiority trials today. And as we will see in the course of this presentation, it is a trial design that presents unique interpretational challenges. So let's just try to work through them now. So basically I'm going to talk about all of the issues that are there with regard to interpretation of the conduct and the results of a non-inferiority trial. And then I will tell you why bother with all of these issues in the first place. So issues and why one has to bother with them. So there's a little bit of a history to be known with regard to non-inferiority trials. Most of us are already aware that the gold standard for demonstrating the efficacy of an intervention is a placebo-controlled trial. So the kind of evidence that a placebo-controlled trial yields is the gold standard, and it's unparalleled. So nobody can dispute the worth of a placebo-controlled trial with regard to proving efficacy of an intervention. However, once there's already an efficacious intervention available, so once the efficacy of an intervention has already been proven, then there are ethical issues with regard to doing further placebo-controlled trials. So it may not be justified to further randomize individuals. And so there comes the question, is it ethical to do further placebo-controlled trials? And it may not be. So this led to the beginning of active controlled trials, where a new treatment is compared not to a placebo, but to a standard treatment. So it's compared to the standard of care. And so 1982 saw the start of equivalence trials, which try to study whether a new intervention has similar efficacy to an old treatment. However, they have now more or less gone out of fashion and have been replaced by non-inferiority trials, because to show equivalence is very, very difficult, because it involves showing no difference with regard to benefit or harm. And so 2010, the FDA drafted a guidance document on non-inferiority trials, and the final document came out in 2016. With regard to non-inferiority, we're not trying to show that it has no difference with the standard treatment, but rather we're saying that it's not worse than the reference or the standard treatment. And we'll talk more about what this not worse implies and what we exactly mean by this. And of course, the number of non-inferiority trials have blown up in medical literature. They've seen a six-fold increase from 2005 to 2015. They're making their way into all branches of medicine, starting off with a major impact in oncology and tuberculosis, and now it's likely that you will come across non-inferiority trials in whichever branch that you work in. So a typical situation is that A is superior to placebo, and therefore further placebo-controlled trials are not ethical, because once there's already a proven reference treatment, we can't randomize further. And so a clinician wants to know, naturally, that if there's a new treatment, does it work the same way as A, as an old treatment? However, to show equivalence is very, very difficult, because it involves setting up both boundaries. So neither worse nor better. And in order to show equivalence, you would require that your results come in a very, very narrow range. And then there's the issue of how much difference can we ignore. Can it be plus minus 1%, plus minus 2%? So this is a difficult decision to make. So investigators have asked that why not we only investigate that a new treatment is not inferior, which means that we're not bothered with whether it is better or not, or whether it is exactly the same. We just mean that it's not much worse, right? So first of all, the first thing to know that in non-inferiority trials, the reference treatment must have been established as superior to placebo. So there would have been a previous placebo-controlled trials that have proven the efficacy of the reference or the standard treatment against placebo. And then this reference treatment is taken as the control in a non-inferiority trial. And this reference treatment or the active control or standard treatment are various terms that are used to refer to the same thing, which is the active control in a non-inferiority trial. So in equivalence, we aim to show that the two active treatments are not too different regarding clinically important outcomes. Whereas in a non-inferiority trial, what we're saying is that what the new treatment has to offer is that not that it is better in improving clinically important outcomes or primary outcomes like mortality or tumor recurrence or variceal bleeds or whatever it is, myocardial infarction, strokes, but rather it is giving us advantages in terms of other things like toxicity and dosing and burden, etc. So the aim is to show that the new treatment may be worse, but not much worse. So it is acceptably worse than the current standard treatment, and the new treatment has other advantages. So the new treatment may be better than the reference treatment with regard to safety profile. So toxicity, the cost may be easier to sustain, it may be more convenient to administer, so fewer pills, less invasive, easier to comply with. So the novel anticoagulants are a great example. A number of non-inferiority trials prove that the novel anticoagulants have less monitoring required with regard to INR than warfarin, and we don't have to worry so much about drug interactions, etc. So less burden. Also, it could be shorter treatment duration. So, tuberculosis is an area where non-inferiority trials have made a huge impact because TB treatment, extends beyond a year, many years sometimes. And so non-inferiority trials were able to show that short treatments are better. Now, to really understand what we're saying here, what we mean by acceptably worse, what is the predefined margin with regard to saying that this is not much worse. Let's delve into that just a little bit more for 2 minutes. And for that, let's first consider a superiority trial. So let's first move away from non-inferiority. Let's consider a superiority trial. It's a placebo-controlled trial. So we're testing the efficacy of intervention A versus placebo, right? And say our outcome is mortality. So let's consider an intervention. In patients with severe COVID-19, say the mortality in the placebo arm is 100 out of 500, that's 20%. And the mortality in the treatment arm, the intervention of concern, treatment A, is 50 out of 500, that's 10%, right? So typically we calculate experimental versus placebo, so that's 10 minus 20. So difference is 10, right? And when we plot it on this graph, over here in the middle we have the line of no effect. So when we're talking about risk difference, this corresponds to 0, right? If we talk about risk ratio or odds ratio, this would correspond to 1. So we're talking about risk difference, so the line in the middle corresponds to no difference, which is a risk difference of 0. We saw that the difference in our mortality between treatment A and placebo is minus 10. So this is where we plot the point estimate. So this is the result of the randomized placebo-controlled trial. However, as you can imagine, COVID is affecting everybody, in millions of people across the world. So it's not expected that a 10% mortality benefit will be yielded every time in every individual, right? So we have a range. You can think of it as a margin of error. It's the range of plausible values consistent with our data. So various people across the world may have different mortality benefits. It could range from -6 to -14. And so this whole range of plausible values, given a certain level of confidence, is the confidence interval, right? So the whole range of values consistent with the data. So over here you can see that in this randomized placebo-controlled trial, the mortality benefit that we got was 10%, but it can range from -6% to -14%. So some people may benefit as little as 6%, or there could be a maximum benefit of 14% with 95% certainty. Now let's consider non-inferiority. Now here, our comparison is with the standard or the reference treatment. And what we are saying is that this new treatment, it may not be beneficial in terms of reducing mortality, but it has other benefits, like in terms of toxicity or convenience or cost, etc. And then we're saying that if the toxicity and the burden advantages are good enough, then we are willing to accept a little bit of excess mortality with this new treatment. In other words, we are saying that we accept that the new treatment may actually be a little worse. In other words, we are saying that there may be some excess deaths with the new treatment, which we are willing to accept because there are other advantages, right? So we accept that it is not worse beyond a predefined margin. And so this is the non-inferiority margin. It is the allowable excess of outcome events that can occur with a new treatment when compared to a reference treatment. So this is the non-inferiority margin, and you can see it's towards the harm side. So these are the maximum excess mortality that can take place with the new treatment compared to the reference treatment. Okay? So say we do our trial, and this is the result that we get, right? So if you look at this confidence interval alone, it's apparent that probably it's possible that the new treatment may actually have no effect. However, with regard to the non-inferiority margin, this intervention is non-inferior, right? So the point estimate suggests that there is no difference. However, it may be better, it may be worse, but we're not concerned with that. We are concerned that it is not crossing our non-inferiority limit. And so here we successfully conclude non-inferiority, right? However, if we get a result like this, over here again, if you just look at this confidence interval, it's inconclusive. So it may be beneficial, it may be worse, or it may have no difference. We can't say. But with regard to the non-inferiority limit, this is crossing the threshold, and therefore we cannot say that this intervention is non-inferior, right? However, if the non-inferiority limit were here, then this intervention or this result is also non-inferior, right? So this tells us two things. Number one, that the non-inferiority limit is key, okay? Everything depends on the non-inferiority limit. And the second thing that it tells us is that the non-inferiority limit must be pre-specified. Because if investigators try to set their limit after the trial results are in, they may be tempted to shift the margin in order to successfully conclude non-inferiority, right? And so it must be part of your protocol, and we'll see that there must be an adequate justification for the margin. Now, this doesn't happen very often, but it may be possible that you get a result like this, which is beyond the null line. So it doesn't include no difference, but it's within the non-inferiority limit. And so this result shows inferiority. However, with regard to the non-inferiority limit, it is non-inferior, right? So this doesn't happen very commonly because you would require a very large sample size for this. But this result is inferior but non-inferior. So this picture is taken from the consort extension for non-inferiority trials, and it tells us that there are 8 possible scenarios with regard to results of a non-inferiority trial and the margin, right? So over here you have a confidence interval that's clearly superior. So it's reducing bad outcomes, it's reducing mortality, it's reducing whatever the primary outcome is. Over here, these are 3 scenarios where the result is non-inferior because it does not breach the non-inferiority threshold, right? So these 3 scenarios, although over here you can say that there's possibility of no effect, over here also there's possibility of no effect, but we're not concerned with that. With regard to the threshold, these 3 results are non-inferior because it does not cross the threshold. Again, I told you this one doesn't happen very often. D does not happen very often because we don't have sufficient sample sizes to get such a narrow interval, but this actually means that this is non-inferior, even though it's on one side of the null line, so it's inferior but non-inferior. Now these 3, E, F, and G, yield confidence intervals that are inconclusive. So we don't know what will happen here. It could be superior, it could be no difference, it could be inferior, we don't know. And moreover, it's crossing our threshold, the non-inferiority line, or the threshold denoted by delta commonly. And so this is inconclusive. F is also same. same as E, we don't know. Could be superior, no difference, inferior, we don't know, so it's inconclusive. G, although it's on this side, even though it's showing inferiority on both ends of the confidence interval, but with regard to the threshold, it's crossing, so again it's inconclusive. And H is clearly inferior because it's on this side of the non-inferiority threshold, right? So let me just reiterate what I just told you in the last 5 minutes. With regard to concluding non-inferiority, what is key is the non-inferiority limit, because what we're saying is that the new treatment may not be better at improving primary outcomes like mortality and stroke and myocardial infarction and variceal bleeds or tumor recurrence, whatever the primary outcome is. It may not be better, but it has other advantages like reduced toxicity and burden. And what we're saying is that given those advantages in toxicity and burden, we are willing to accept a little bit of increase in the primary outcome. And that is what the non-inferiority limit is. It is the maximum allowable excess of outcome events in the new treatment compared to the standard treatment. Okay, so why is this important to know? Let's consider this randomized controlled trial. It's on acetic acid versus radiofrequency ablation for the treatment of hepatocellular carcinoma. So the highlighted portion is the main result. They said complete response was non-inferior to RFA, that's in acetic acid. So the difference 8.3% ranges from minus 2.5 to 29.2. And they say that in the conclusion, acetic acid and RFA have similar efficacy in treating small HCC. PAAI could thus be a cost-effective alternative in situations where RFA is either unavailable or unaffordable. However, if you look at this result, they say that their non-inferiority margin is 10%. However, the confidence interval ranges from, so basically PAAI was in their result 8.3% inferior, but it could range from 12.5% inferior to 29% superior. So this is actually crossing their non-inferiority threshold. And so this, like many others out there, is a mistaken claim of non-inferiority. Had they plotted it on the graph, it probably would have, been clear that this result is actually inconclusive. And so this was actually picked up by a systematic review in JAMA, where they talked about misleading reporting or spin in non-inferiority randomized controlled trials. And so this trial was included there. And literature is rife with such mistaken claims. Another very often, a very common lapse in judgment is to claim non-inferiority when there are statistically non-significant results from a superiority trial, right? And the reason that's wrong is because a non-significant, non-statistically significant result may only come because we don't have sufficient numbers in the trial. So a p-value will not tell us whether there's actually an absence of an effect or if we don't have enough numbers to yield an effect, right? So it could be somewhere here. This one, the E. Yeah, E or F, yeah. So again the same thing, 12.5 to, they said 29%. So it would lie, so it's inconclusive. Yes. So that depends. If you take a harm outcome or a benefit outcome, is the same thing, but basically it's an inconclusive result because it's crossing the threshold of 10% that they took. Yeah. Any other questions so far? Okay. So this trial did it right. This was a non-inferiority trial on the treatment of chronic hepatitis B compared to interventions. And so they've actually plotted. So their non-inferiority margin was 4%. And then they plotted their results. Their primary outcome was viral suppression. And so then they did not make that mistake, right? And so consort, actually, this is taken from the consort document, extension for non-inferiority trials. And they say that for the outcome for which non-inferiority was hypothesized, a figure showing confidence intervals and the non-inferiority margin may be useful. And certainly it is, because those authors would not have made that mistake had they plotted that graph. Okay, So the obvious question is, how is this non-inferiority margin set? And let me tell you, in epidemiology, this is one of the areas that sees the most controversy. There are two ways. There's the clinical and the statistical method of setting the non-inferiority margin. What the clinical method says is that it involves serious consideration of what you are giving up with regard to the primary outcome compared to the toxicity and burden advantage. So it's like making a value and preference judgment. You're weighing in the harms and the benefits. If the benefit with regard to toxicity and burden is very large, we may be willing to let go more of the benefit with regard to primary outcome. For example, if there's a new chemotherapeutic agent for hepatocellular carcinoma, which claims that there's reduced GI toxicity, and says that there's 5%, there may be the non-inferiority margin is 5% with regard to tumor recurrence. One has to ask oneself, would patients be willing to accept a 5% increase in tumor recurrence for the benefit of GI toxicity? And so it depends on the outcome. What is the outcome? Is it mortality? Mortality, most patients would not incur more than 1% increase. If it's something like hospital stay, or if it's something like viral suppression, it depends on the outcome, So it involves a value judgment, weighing in what you are letting go of with regard to the primary outcome and what you are gaining with regard to the toxicity and burden advantage. So it's a clinical judgment in that it involves weighing in what the downsides and the benefits are. And then there's the statistical approach, and for whatever reason, or maybe a number of reasons, the Food and Drug Administration does not endorse the clinical approach, even though there are many detractors of the statistical approach saying that it does not take into account what the outcome is, does not take into account what the toxicity advantage is. But the FDA uses the statistical approach to setting the margin. And what is the statistical approach? Well, they first consider a placebo-controlled trial or a meta-analysis of randomized controlled trials involving placebo, and they take out the least plausible benefit from that placebo-controlled trial. So this is the result of a previous placebo-controlled trial that proves the efficacy of the standard treatment versus placebo. And so over here you can see that the result of the placebo-controlled trial is that there's a 3% reduction in mortality with the standard treatment, but this could range from 2% to 4%, right? So what they're saying is that in this placebo-controlled trial, placebo had a 2% excess mortality. So the least plausible benefit is 2%, right? Now the FDA says that we want to preserve half of this benefit. So obviously, the inferiority margin cannot be 2% or more, because that would make the new treatment as good as the placebo or as bad as placebo. So they say that we will preserve half of the benefit of the standard treatment. So the least plausible benefit is 2%, so they keep the non-inferiority margin as 1%. So it's preservation of a fraction of the benefit from a placebo-controlled trial, right? So any questions? So this is a statistical approach which a number of epidemiologists say is not the correct way of going about things, because it does not consider what the outcome is, and it does not consider the gain in terms of toxicity and burden, right? But it's a purely statistical approach that the FDA endorses, and this is what they use.
Say that again. You're saying that the threshold is actually
right.
Proportion of the benefit.
Exactly. So in the statistical approach, what we're saying is that we consider a placebo-controlled trial of the standard treatment, right? So this is the placebo-controlled trial that has proven the efficacy of the standard treatment, and the least plausible benefit from the placebo-controlled trial is 2%, because the confidence interval ranges from 2 to 4. So this is the least plausible benefit. What they're saying is that in this placebo-controlled trial, placebo had a 2% excess mortality. So with regard to setting a non-inferiority margin, obviously we cannot keep 2%, because that would make the new treatment as good as placebo. So we want to preserve a fraction of the effect of the standard treatment. And what FDA says is that you preserve at least 50% of the benefit. So if the least plausible benefit is 2%, we keep non-inferiority margin at 1%. So it could be at least 50%, could be 60% also, but we have to preserve a fraction, at least 50% of the benefit of the standard treatment against placebo. Okay. All right. So, this actually puts us in a very dark place because previous studies have to be relied on in order to define the non-inferiority margin. And so the challenge there is that trial designs may change over time, patients' intervention and outcomes may change over time, clinical practice may change over time, and effects of treatments may change. And this is called constancy. And I'll talk more about this when I talk about two more concerns about non-inferiority trials. But consider this systematic review, which did a systematic review of non-inferiority margin sizes for testing mortality. And what they said was that 111 articles were included for the analysis, and mortality was an outcome in all of these trials. So around 21% had mortality as the sole primary outcome, and 79% had it as a composite outcome. And the overall median non-inferiority margin was 9% for these trials that included mortality as an outcome. There are multiple surveys out there, inpatient groups, etc., that suggest that patients would not be willing to accept more than a 1% difference. But some trialists took as much as 10% increase in mortality with regard to non-inferiority. And so, there comes the question of whether, with regard to setting of non-inferiority margins, are we really taking into consideration the values and preferences of patients? So I told you there are three main concerns. I've already spoken about setting of the non-inferiority margin. There are two more issues, preserving the effect of the reference treatment and then the kind of analysis we should do. So in order to tell you about the second concern, I'll tell you a story. So in the recent ILBS sports meet, there was a badminton match. Nurses were playing. And there was a senior amongst the nurses batch that would always win. So she was the defending champion. She was state level player, and no one would dare to put a pitch against her, to really come out and try to challenge her skills. And so, as you can imagine, because of this player who was so good, the sports meet was seeing very limited participation from freshers. So the new batch was hardly participating at all. But then, after much encouragement and after much encouragement and cajoling, there was one fresher that mustered up the strength and the courage to play against the state level player. And so the warden, before the match started, the warden went and whispered something in the ear of the senior, and lo and behold, the fresher won, right? So what do you think could have happened? Most of you are probably thinking, it's probably because in order to encourage the new fresher or the new player, the senior had a less than intense playing of the match, right? So consider now a new antibiotic regimen for methicillin-resistant Staph aureus, right? So there's a standard treatment for MRSA, and there's a new treatment that's come out, and it took 3, 4, 5 years for the new treatment to come out, right? But by then, the standard treatment may have already, the pathogen may already have gained resistance against the standard treatment, right? So that means that the effect of the standard treatment is not preserved when we're talking about comparing the new treatment to the standard treatment, right? Now, this doesn't happen, but if we consider 3-arm trials, say there are 3 trials, 3 arms in the trials, a new treatment, a reference treatment, and a placebo, then we have to show, then if we had the power and if we had the means, we would have been able to show the superiority of the reference treatment against placebo, the new treatment against placebo also. However, we can't do this. We can't do 3-arm trials. We can't randomize to placebo when there's a standard treatment already. But if we do a 3-arm trial, and if we fail to show superiority of even the standard treatment over placebo, then that means there is a defect in our trial. So this is called assay sensitivity, right? If even the reference treatment is not able to show superiority over placebo, in that case we have not preserved the effect of the reference treatment, and therefore this is a defect in the trial. Now, with regard to non-inferiority trials, we only have 2 arms, right? We don't have a 3rd arm. We don't have the placebo arm. So we have only 2, the new treatment and the reference treatment. Now, we have no idea how the treatment compares to placebo because there's no placebo arm. So we have to rely on previous studies to consider and establish that the reference treatment has efficacy. So historical studies, historical controls, have a huge role to play in non-inferiority trials. And this is why we're left in sort of a dark place, because we have to rely on previous studies to define the non-inferiority margin, and to also rely on it as to have efficacy still preserve the effect of the reference treatment. So as you can imagine, this leaves a lot of room to make inadvertent mistakes, but it also leaves a lot of room for manipulations, right? So investigators, if they want, they can prove non-inferiority by enrolling less responsive patients. So if the patients are less responsive or less adherent, less compliant, then it is very easy to show non-inferiority. Similarly, if we give low dose of the intervention, or we give it for a shorter duration, again it is very easy to show non-inferiority in this case. Of course, with regard to the outcome, we may set a unjustified non-inferiority boundary. We've already seen how that leads to a mistaken conclusion of non-inferiority. Or it could be a defect in the study design, so poor adherence, poor loss to follow-up, or low event rates. So there's a lot of room for making mistakes or making manipulations with regard to preserving the effect of the standard treatment in a non-inferiority trial. So we have to guard against unwarranted conclusions, because we have to ask, was the effect of the reference treatment preserved? The investigators may be able to prove non-inferiority even if not true, if they enroll less responsive, less compliant population, or administer decreased intensity of the intervention, or they have too short a follow-up. Now, how to check for this? Of course, we have to look at the study design, and we have to look at the results of the control arm or the reference treatment. So the control event rate would give us some idea of whether the effect was preserved with regard to reference treatment. But again, this is a gray area, because we don't know if the patients were prognostically different than the placebo control trial, or if it's actually preserved or not, right? So we have to consider design issues, the participants' endpoints, and other important aspects of the trial. The non-inferiority trial should be similar to the trial that was used to prove efficacy of the standard treatment. And this is difficult to do. The kind of population, the kind of outcomes that we are considering now may not be the same as the trial that was done to prove efficacy of the standard treatment. For example, in earlier HIV studies, deaths was used as a primary outcome. However, over time, deaths reduced. So the new outcomes such as viral suppression and clinical events, etc., were used. So outcomes do change over time. Populations change, as we saw with the example with MRSA. And so we sometimes cannot preserve this. And this is a huge issue with regard to non-inferiority trials. Now, the last issue is, I'm going to ask you a question. Yeah. It should not be too worse. Yeah. You mean mean with regard to setting the margin?
No, the endpoint. When you do a inferiority trial, you will have
Yeah.
outcome measure. So what will be your primary and secondary outcome?
No, the primary and secondary is same as what you would consider for a superiority trial. So the primary outcome would be patient important outcomes like mortality or tumor recurrence or cardiovascular events or variceal bleeds. So it's the same as the superiority trial. But with regard to setting of the margin also, we consider these primary outcomes only.
But is it cost going to be an important margin, important endpoint here? Because this one treatment may be as good as the previous one.
Yeah.
But it may be less expensive.
Yeah.
Should cost effectiveness or cost be the more, maybe the primary outcome measure?
No, because the reason we are coming out with this new treatment is because it has those toxicity and burden advantages in the first place. So we already know that, we already know that it is cheaper, or it has less frequent dosing, or it has a shorter duration course, or it is easier to comply with. We know that it's there. And that is what the new treatment has to offer in the first place. Because there's already a standard treatment that's there for the disease. The reason we're coming out with this new treatment is because it has those toxicity and burden advantages. That is what it has to offer. And what we're saying is that in view of those toxicity and burden advantages, we may be willing to accept a little bit of an increase in the primary outcome. So a little bit of excess mortality, a little bit of excess variceal bleed. But how much excess, that is the question. That is the non-inferiority margin. How much can we accept? So the final part of the presentation is a question about analysis. So let me tell you about this trial. It was published in the New England Journal of Medicine, which compared a new statin, a new cholesterol lowering drug, to placebo. So let me simplify the numbers for you. It included 2,000 individuals. There were 1,000 in the cholesterol lowering drug arm and 1,000 in the placebo. Now, in the intervention arm, this was a superiority trial, a placebo-controlled superiority trial. In the intervention arm, there were compliers and non-compliers. So 500 complied, 500 did not comply. And in those that complied, there was 15% mortality. Whereas in the placebo arm, there was overall 20% mortality. So this was an industry-sponsored trial. So what the industry said was that if you take the treatment, you have a 15% mortality. If you get placebo, there's 20% mortality, and this difference is very, very statistically significant. So p-value 0.0003, and so the drug works, right? So my question to you is, do you have anything else to ask, or do you want to know anything else with regard to the benefit of this drug, or are you happy taking it? Yeah, so non-compliers had a 25% mortality. Anything else you would want to know? Of the compliers versus placebo, or?
Reasons for non-compliance.
Yeah, reasons for non-compliance.
Reasons for non-compliance.
Yeah, there was
and
some.
That will stand against the drug being available, being used by the users.
Right, exactly. So there's some adverse event that's precluding high compliance of this drug. So that's what the industry said, that there's some adverse event which is not allowing the drug to be used by everybody.
Yeah.
But if you take it, there's a huge advantage.
Yeah, but when you do the analysis, you can't exclude those 500. That will be included in your intention to treat analysis.
Right.
You can't exclude those 500.
Right, exactly.
That will come into the whole picture of the thing.
Right. So, anything else anybody wants to know?
This p-value is highly significant due to higher sample size.
Well, of course, but it's also because there's a huge benefit also. The effect size is also huge. Right, exactly. So even in the placebo arm, there are compliers and non-compliers. And even within the placebo arm, you can see that in compliers, there's 15% mortality, and in non-compliers, there's 25% mortality. So even in the placebo arm, you can see that there's a huge difference. The reason what Sir was saying we have to include all the patients in each arm is because if we exclude non-compliers, what we're taking out of our trial is a group of people that are prognostically very different, in that they are prognostically worse. Because non-compliance itself is a prognostic factor in the sense that people who comply with the treatment are also those who comply with other lifestyle, recommendations like good exercise, good diet, or they also. Again, we can't do that because the reason we randomize is because we want to produce two groups that are prognostically balanced. So these two groups of people, 1,000 versus 1,000, they have the same destiny in that they are prognostically exactly balanced. So that's why we can attribute effect of the intervention to a certain intervention, because this is actually intention to treat. The reason we do intention to treat, which means that the reason we include all the participants into the arm to which they were randomized, is because we have gained prognostic balance, 1,000 versus 1,000. If we take out a proportion of the individuals from this trial, we're losing that prognostic balance. So we're losing the advantage that randomization gave us in the first place, right? Which is why intention to treat is done. It is to preserve the prognostic balance that randomization created in the first place. So intention to treat is all patients analyzed, keeping them into the group to which they were randomized, irrespective of whether they took it or not. However, in a non-inferiority trial, the picture gets reversed. Okay? So the usual standard is intention to treat because A, it preserves the prognostic balance, and B, it's a more conservative estimate in the sense that it's more difficult to show effectiveness of an intervention with intention to treat. If a certain number of people do not take the drug, then it is more difficult to show that the intervention works with intention to treat analysis than a per protocol analysis. So that's why a usual superiority trial intention to treat is the usual standard. It is the correct analysis to do. Because in a superiority trial, it is conservative. However, in a non-inferiority trial, in this trial? Yeah. There was nothing wrong in the sense, the reason, what the drug company here was saying was that if you take the drug, there's 15% mortality. If in the placebo arm, there's 20%. When in fact they should have compared this whole group to this whole group. They should have told us the mortality benefit of this whole group versus this whole group, and you can see that there's actually no benefit because it's the same across these two. And also ITT yields a more conservative estimate. So in superiority trial, ITT is the correct analysis. However, in a non-inferiority trial, it's anti-conservative. So in a non-inferiority trial, say in the standard treatment, there's less compliance. In that case, it would be very easy to show non-inferiority because the effect of the standard treatment is nullified. Right? So you can see this is an example, beta blocker versus ACE inhibitor in heart failure. There's 5% NI margin with regard to deaths and hospitalization. So what they're saying is that we accept a 5% increase in deaths or hospitalization. The result was 4.4% with ITT and 5.1% with per protocol. So here you can see that it's actually anti-conservative with regard to intention to treat, right? So what I'm saying is that in a non-inferiority trial, say a considerable number of people in the reference arm do not take the treatment, right? Now, if we compare the new treatment to standard treatment, we did not get the effect in the standard treatment arm because they did not take it. So in intention to treat, it's easier to show non-inferiority. Now consider another treatment where the whole population is non-compliant. So neither the new treatment works, neither the standard treatment works because there's a non-compliant population. Intention to treat, it's easy to show non-inferiority. In non-inferiority, it should be both. So you should do both per protocol as well as intention to treat. If both of them are suggesting the same thing, we would be more comfortable. And if they're at odds, then that sort of raises a red flag. But we must do both intention to treat and per protocol. And this was actually published in the journal of Clinical Epidemiology, which talked about reporting of non-inferiority trials, and they said that only 44% do both ITT PP, only 53% give supporting evidence of non-inferiority margin, and only 2% of all non-inferiority trials met all the criteria for good reporting. So this is a huge lacunae out there with regard to adequacy of reporting of non-inferiority trials, certainly with regard to justification of that margin. There are hardly any out there that justify or give an adequate justification of how they kept the margin. As we saw with that paper, up to 9%, 10% mortality margin is kept when in fact patients would not be willing to accept so much of an increase, right? And so if you want to read more about this, this is a great summary. It was published in the NAJM, the challenges in design and interpretation of non-inferiority trials, excuse me. And the consort has a statement that extends the reporting guidelines from RCTs to non-inferiority and equivalence trials. So I think I'll summarize now. So this is a user's guide to avoid getting misled by non-inferiority trials. We must interpret the result of the non-inferiority trial using the 95% confidence interval in relation to the non-inferiority margin. So this would allow us to guard against the mistake that those authors made in crossing the threshold. And it's better to display it in the form of that picture or that figure that I had shown. The choice of the margin must be justified. There are two ways, clinical and statistical. There are many detractors of the statistical approach saying that it's a value and preference judgment that has to weigh in the benefits and the toxicity burden and the loss of benefit with regard to the treatment. We have to guard against unwarranted conclusions of non-inferiority, and that's by seeing whether the effect of the standard treatment was preserved. And an ITT analysis may be anti-conservative with regard to a non-inferiority trial, so we must do both for protocol and ITT. So I'm happy to take any questions now. Sorry?
The sample size is, what is the, it should be a very large sample.
No, so in a non-inferiority trial, usually we land up with a sample size that's smaller than a superiority trial. Usually, it's around 1/4 of that required in a superiority trials. So a usual, rule of thumb for sample size calculation, if you do 16p, 100 minus p upon d square, d is the effect. That's usually for superiority trial. For non-inferiority, just change it to 12. So 12p into 100 minus p upon d square is, you can just use this, while you're walking and talking. It's a rough formula. So 12p into 100 minus p divided by d square, where d is the non-inferiority margin.